Good morning, everyone. Thank you so much for being here for the final day, the first session. So my name is Lisa Higgins and I am from Melbourne, Australia, and I am joined by my co-chair, Ling Lu. I would like to introduce our first speaker for the day, Natalie Leos. Thanks, Natalie.
Thank you for the kind introduction. Good morning, everyone. First of all, I'd like to thank the organizing committee for the invitation to speak about recent organizational changes that we made in our center and that could impact quality of care. These are my disclosures for the present talk. First of all, what is intensive care? In the UK definition, it's a service where specialized care is delivered by trained personnel, whereas for the World Federation of Intensive Care Medicine, it is an organized system. So, although both definitions include similar core descriptions of the patient, the healthcare worker, or the capacity, the second one goes one step further by defining an ICU as not as a space, but as an organized system of places within a hospital setting. So there's significant variation, actually, in the epidemiology of ICU organizational structures in countries distinguish between general intensive care, specialized units, or even high dependency units, and this is very variable according to hospital size, catchment area, and case mix. What is quality, on the other hand? So this is actually the founding moment of contemporary healthcare quality movement in 1965, when Professor Don Abedian was commissioned to review the research on quality assessment, and his lasting framework was composed of structure, which encompasses settings and qualifications of caregivers in administrative systems, process, which include components of care delivered, outcome, which include recovery, restoration of function, or survival, and last but not least, culture. Contrary to what might seem obvious, it's mainly organizational changes in the ICU departments that have driven better outcomes, whether it's mortality or other endpoints and reduction of costs. In the past decades, more than amelioration of drug or treatment discoveries, and the two main drivers were implementation of electronic health records and transitioning from open units where referring specialists cared for patients to closed units run by critical care medicine specialists. In the above shown studies, apart from mortality, other endpoints such as ICU length of stay or hospital length of stay were also impacted favorably without using more resources. Now, what's a big ICU? This is a snapshot of centers' demographics data from the Worldwide EPIC-3 study. And as you can see, the median number of beds per center was 12, with an average of 700 admissions a year. The vast majority of those centers that participated were closed format units, up to 80% of them. This is a worldwide snapshot, predominantly academic centers, and with a mixed medical surgical activity. This is the report that came out last July, in 25, on organization and financing of intensive care services in Belgium. And it showed a high density of intensive care services with large differences between provinces, and that globally, these ICUs identify themselves as general, medical, or surgical, pediatric, or burn units. And as you can see, the median number of beds per service is 7 to 12, which is not a very big ICU, right? 61% of general ICUs in Belgium, they host 7 to 12 beds in median. Now, this is the institution in which I work, which hosts 58 ICU beds out of more than 1,000 licensed beds, which used to function within 8 units until 2019. And these units were called closed because we have full coverage 100% of the time with intensive care trained specialists. And we had, for regulatory purposes, had to move to a one mixed general ICU between 2019 and 2023. And we shifted the model in January 25 to one big mixed ICU with hybrid units, which are closed, that's neuro ICU, cardiac surgery ICU, and trauma and burn ICUs, in which we co-manage patients with primary care specialists. Now, where's the evidence backing specific organizational structures in the ICU in terms of amelioration of quality of care? There's a lack of high-quality trials, mainly because of methodological reasons, and most data compare indirectly. There's no direct comparison, open versus closed, or low-intensity versus high-intensity units. Evidence specifically isolating the approach we took. Hybrid ICU models is scarce, and we have mainly retrospective and before-after studies. That's because methodologically it's quite difficult to randomize, it's not feasible to randomize the patient at the patient level because sectorization actually affects the whole unit. There's safety and staffing equity that are impacted, which poses ethical on top of practical challenges, and isolating one single element amidst staffing and workflows changes is equally challenging. We do have cluster randomized trials, which do not focus on the whole process of changing the organization, but rather on quality interventions, such as intensivist staffing schedules, quality interventions, that is, compliance to bundles, and tele-ICU lately. What is established and what is the most obvious quality impacting criterion is the transition from open to closed units, which was already highlighted in a systematic review 25 years ago almost, and that looked into ICU staffing, low versus high intensity, and patient outcomes, mainly hospital and ICU mortality and length of stay. So low ICU physician here was defined by no presence of intensivist or elective consultation, and high ICU staffing in closed units, fully staffed, was defined by either you have 100% coverage with ICU trained specialists, or you have a mandatory consultation. Well, figures speak for themselves, and this is why in 2026, well, we have over 80% of units working in a closed format. And the advantages are improved outcomes, which are evidence-based, standardization of protocols, centralized decision-making, better resource allocation and utilization, but more importantly, actually, it's better perception of care, especially from healthcare workers. And this is important because you do know that we have problems with retention of personnel and high-level burnout prevalence. Papazian published in 2023 more than 40% high-level burnout in healthcare workers in the ICU. And there's also studies mentioning that patient and family satisfaction is better when patients are hospitalized in closed units. Now, the drawbacks are known. There's an inability to stretch in case of high strain periods. And this leads to paradoxical lower adherence to protocols. Simple things such as bundles for VTE prevention are less well followed when you have a high strain on a closed unit. There's also concerns about exclusion of primary providers from decision-making, especially when end-of-life decisions are at stake, with loss of continuity and resistance in some settings from stakeholders. Now, this is evidence towards reduced mortality is well established in some populations of patients, such as neurocritical patients, and this goes back to 20 years ago, even 25 years ago. And studies had already alluded to that in the 80s and 90s. And actually, there's probably better management of hypertension, coagulopathy. There's also decision about end of life, which is more precise by intensive care specialists. And there are other potential factors that can explain that, and this is well established. Also well established is better outcomes in dedicated cardiac surgery units run either by intensivists or dual-trained cardiology intensivist specialists with decreased hospital readmission rates, reduced post-operative complications, and lower in-hospital mortality. On the other hand, risk-adjusted outcome differences across such units are unknown, and controversy exists. This is the only retrospective large-scale study that compared the outcomes of patients admitted either in so-called specialty ICUs or general ICUs, and this was conducted in more than 100 hospitals in the US. Patients were pooled by similar diagnoses and procedures such as abdominal surgery, acute myocardial infarction, pneumonia, ischemic stroke surgery, intracranial hemorrhage, and the primary exposure was the type of ICU to which the patient was admitted. Was it a general ICU, an ideal specialty ICU, or a non-ideal specialty ICU? And the authors looked into more than 80,000 patients, and these results show that admission to an ideal specialty ICU was not associated with improved risk-adjusted survival compared with admission to a general ICU among a priori selected diagnoses. There was no consistent relationship between specialization and ICU length of stay either, and there was a hint toward improved survival in cardiothoracic surgery patients admitted in specialty ICU, and clear association of boarding with mortality. What about hybrid models? The advantages are shared responsibility with the primary care specialist, improved protocol adherence and quality of care, that remains to be established, flexibility for admission in ICU high strain, which in turn is distributed across more practitioners than when you have closed units. And this leads to better retention of personnel, less burnout. Presence of continuity of care with primary specialists is equally important. I think you'll hear something about that later on. However, the drawbacks are the same in terms of shared of responsibility. Who is accountable? And this is important. It's not anecdotal. This is a daily routine questioning about efficacy of communication towards healthcare workers, families, and patients. There has been a report of reduced efficiency compared with closed ICUs in terms of slower decision-making, heterogeneous practice patterns, and difficulty implementing standardized protocols, and cultural and operational complexity. Usually, it's high-volume ICUs such as ours, more than 40 beds, that tend to specialize primarily on the basis of disease prevalence. These are our figures in terms of admission and origin of admission of patients, level of staff specialization, and predictability and similarity of recovery patterns. I found actually two studies that are close to our model, one in cardiac surgery patients, showing that the contribution of 24/7 coverage by ICU physicians was able to decrease transfusion requirements, mechanical ventilation duration, and hospital length of stay. And the second concerned trauma patients transitioning from a general ICU to a hybrid model with permanent ICU-trained specialist staffing. And it was also associated with less ventilator days and respiratory complications and re-intubation rates. This is our experience. We transitioned in January 25. There was a very recent assessment of the first 10 months of the hybrid model compared to the 2 preceding years. And we analyzed more than 3,500 patients in the before period and more than 1,000 patients in the after period. And what we observe, and these are preliminary results, an overall reduced mortality at 90 days, and this concerns mostly cardiac surgery patients in whom mortality has gone down 50%. Now, these results are preliminary, of course. In conclusion, organizational changes have driven the best part of better outcomes in the ICU. There's no high-level evidence available. Closed units are better than open units and probably better than hybrid ones, but these may be acceptable alternatives when you have financial constraints and when patients are of moderate acuity. CICU, neuro, and trauma patients benefit from specialized ICU care, and hybrid model potentially advantageous, but needs to be assessed prospectively, quantitatively, and qualitatively. Thank you.
Questions from the audience?
Yeah.
Oh, please.
Thank you very much for the great presentation, Gabor from Dublin. Just interested in your hospital structure. In other words, who is your boss when you kind of need to escalate problems from ICU perspective? I saw a structural picture at the beginning, and it looks like you're overarching many specialties across the board. Mm-hmm. And that's, I think, it's very important because what we struggle with is our boss is a surgeon, our boss is a medicine, our boss is emergency. Who is your boss in that structure?
Okay, my boss is in the room and it's my head, actually. So he's coordinating that, but in each hybrid unit, specialists, my colleagues work with primary specialists on a daily basis. I mean, they do not take any other than ICU decision without the primary specialist. So coordination happens at the head's level, and in the units, whether it's the mixed one or the hybrid units, collaboration happens directly between intensive care specialists and primary care specialists. I have to admit, I have a bit of a trouble working in those hybrid units. Yeah. Does that answer your question? Okay.
Other questions? No, maybe? Yeah, thank you. Thanks again. And I think maybe we can switch to the next speaker, Professor Hannah Wolski. And the topic is how important is continuity of care, please.
Good morning. Thanks for staying on Friday morning here. So I'm going to talk about continuity of care and sort of maybe challenge a little bit some of the assumptions around how we value it in terms of the care we deliver in the ICU. And I want to start out by saying, I think we would all kind of agree that the idea of continuity of care is a patient-centered outcome. There's very few patients and families who would sort of raise their hand and say, I'd rather see a different doctor every day than the same doctor over the course of my stay. Although you can also argue if they don't like a certain doctor, sometimes they're very happy when that doctor changes over. But on average, I would say that definitely is something that patients would prefer. But I want to do a couple of things. I want to look at kind of what enabled the concept of continuity of care to become such a strong factor in the way we provide care. I want to talk about why continuity of care is so much harder to deliver now. And then I actually want to challenge the assumption that continuity of care is always better in terms of the care we provide for our patients. So if we think about the ultimate continuity, It would be all staff available 24/7, 365 days a year for our patients. Obviously, there may be some real old timers in the audience who still do this, but I would say almost no one has experienced this way of delivering intensive care since it kind of first started. But until not actually that long ago, certainly into the 2000s in some centers in the US, there was certainly a model of being on call 24/7 for an entire month straight. And so, to me, this feels unfathomable doing this. And yet, this was a very common model, and the expectation here was that you were providing that incredible continuity that we value over and above everything else. So I think to kind of dig back and understand how and why this was even feasible is actually to recognize that intensive care units come out of the 1950s and early 1960s when they were first being set up. And I want to go into kind of a cultural aspect of being a physician back in that day, which is that the percentage of doctors who were women was 6%. So it was this is US data, but massively male-dominated profession at the time. The marriage rate for men was 90% in the US. And only 20% of married women worked outside of the home, and I would argue that for doctors, that number was actually probably much, much lower because there was no financial need. So you have a workforce that has stay-at-home wives who are being asked to work a lot. And that model is obviously very, very, very different from what we have now. And I pulled some data. This doesn't even go back to the 1950s. This is just back to 1965, Survey Day of the United States of parents' time and housework. And you can see back in 1965, 31 hours by the women and 4.4 by the men or fathers there. This is per week. And kind of even more staggering, parents' childcare time per week was 2.5 hours on average provided by fathers. And this, again, this doesn't go back to the 1950s. We're already into the 1960s here. And so I just put this up here to really make the point that it was a very, very, very different world. And I thought about this on the bus one day coming home from work after a long day in the ICU, and I was like, oh my God, I need to buy milk because I won't have any milk for my coffee in the morning if I don't get the milk. And then I sort of thought, wow, there was a time when if I was the ICU physician, I would never have had that thought going home. There would be someone at home to take care of this. And it really is different in terms of what it allows you to potentially do and the expectations of being on call. And what I call back in the days the giants, I think it's also important to understand how ICUs themselves differed. ICUs were smaller, so generally you were not taking care of that many patients day to day. What could be done for patients? Actually not a lot, right? You might intubate them, give them an x-ray, give them some blood, give them some antibiotics, and sit and wait. And so this churn of tests and numbers and all of this stuff coming at you all day just wouldn't have been there. How much help did you have? Well, certainly in academic centers, which is where ICUs were primarily clustered, there was a lot of help. There were a lot of trainees around, and there weren't work hour restrictions on them in the same way. How did nights and weekends work? Well, junior trainees and nurses would be at the bedside, and I can tell you I experienced this as an intern at Columbia University in the medical ICU, being on call as an intern. We did not call the attending. It just wasn't done. And now that has changed, right? But you can be on call for a month straight and, quote, on call at night if you're never actually going to be called. You can't be on call at night for a month straight if you're getting called 5 times a night. And then I think this is really important. I think expectations of patients and families back in the early days was very, very different. They did not expect daily updates. They often weren't even allowed in the unit if they were family members, right? There might be a half-hour visiting hour every day or every other day. And so that time spent and the expectation that you would engage with families on a daily basis wasn't there either. So why is continuity of care so much harder for us to try to even deliver now? Well, ICUs are bigger, workforce is more diverse, administrative and other support has definitely decreased, patient complexity has increased, the speed and expectation around the delivery of care that we provide has increased, and there's a greater churn of patients coming in and out of units on a daily basis with a higher cognitive load. Length of stay of patients in that regard has also gone down, and I would argue family expectations have increased. So what do models of care look like now in terms of sort of this continuity question of how many days in a row do people work? Well, we recently did a survey of US ICUs. This is not a sort of well-balanced survey of units. We tried to get that across the US and failed and ended up doing a kind of send out to societies and ask people to respond type of survey. But you can see the average was still, has shifted down from that month or 2 weeks that was more common, but is still generally 7 days. But you can see there are still places that have 14 or more days and also going in the opposite direction. Even more recently, we just completed a survey, the same survey in Canada. So I've got some Canadian data that's not yet been published that really shows pretty much that same distribution, with most people favoring 1 week on. Now, there is one of the questions, of course, that comes up is if you reduce this continuity of care and have people on for shorter periods with more handovers, does that impact patients in terms of their outcomes, that degradation of information in that handover? This was what was a target trial emulation that was done relatively recently, where they looked at units where they had the intensivists on for 2 weeks straight, and they looked at the patients admitted in the first week, where they would, in theory, have 2 weeks of continuity in their care, versus the patients admitted in the second week, where the maximum they would get with that first intensivist would be a week on, just to see whether that demonstrated any difference in mortality for the patients admitted in the first or second week. And they could find no signal for difference in mortality or for length of stay. We similarly looked in Australian data at this question, where we had surveyed along the same lines as the US and Canadian data to ask people about their units and how many days they had worked, how they worked on average in the ICU in a row. And we are actually able to link those responses to patient-level data from the ANZICS database, and to ask the question then, what are the outcomes associated with different durations of time on consecutive days worked? And what we found was that there on the left is all patients, in the middle survivors and decedents, that actually, as the continuity of care decreased, meaning fewer days on in a row, the ICU length of stay actually decreased. Which was not the signal that I think we were split, I'll be honest, in our group as to which way we thought this would go. But what's important here is you're not seeing it just in the decedents, right? This isn't just new intensivist comes on after 3 days, looks at the patient and says, yeah, right, let's just stop what we're doing here. This was across survivors as well as the decedents. And importantly, we also did not see any signal for any changes in mortality associated with the difference in consecutive days worked. So, this is hypothesis generating, but I think it does really challenge the expectation that, it's got to be bad for patients if we reduce the number of days worked. And I have a theory about this, which is that we overestimate the importance of continuity and underestimate how complex our patients are, such that having another pair of eyes on the patient on a routine basis actually is beneficial at times. And this has been nicely shown. It's single center study, but I think is really interesting work from a unit that I used to work in at Sunnybrook. This was done before I arrived there, where Andre Amaral was leading this study, and he looked at the fact that they had a model where the fellows were on every night in the hospital covering. And sometimes they'd been on all day long, taking care of those same patients, and sometimes they came on for the night, and so they were cross-covering new patients for the night. And he grouped patients based on the number of nights they received sort of same coverage or cross-coverage during the time they were in the ICU. And he had 2 groups where the cross-coverage time was either an average exposure of 33% of the nights on or 67% of the nights on. And so that was the difference between the groups, so nice split. And what did he find? He found that on average, adjusting for patient-level variables, the ICU mortality was reduced with increasing number of nights cross-covered. Now, again, this is not what you imagine, right? You think knowing the patients for longer is always going to be good. But what's interesting about this study, why I like it, is he was able to delve a little bit into why mechanistically this might be the case. And he actually looked at what happened at night. And so looking here, fellow cross-covering there is on the left and no is on the right. He found that nighttime decisions varied in terms of the number. There were more decisions taken when there was cross-coverage, 19.3 versus 10.4. There were, in fact, more CT scans done, 5.0 versus 0.8. more changes in antibiotics, and also, interestingly, different fluid management on the nights patients were cross-covered versus not. So, this is really just supposed to, again, it's single center, it's just about fellows in one particular unit, but I think it really pushes you to think hard and long about the assumptions we have about where our values are and what matters most in terms of the care of these patients as they have gotten more complex, more challenging, with more demanding families in a way that just was not the case when this mantra of you've got to know your patient and see them all the way through their entire stay in the ICU, that's the best for them, really came into being. I think another area that's interesting to think about, and there's very little data on this, but this is one of the studies that tried to tackle this, is this question of the burnout and fulfillment of the providers themselves. And some people may say, you know what, I really love being on for a month straight. I love taking care of patients and getting to know them. But I think for the vast majority, there is concern that when pushed to work that many days consecutively, that it really can lead to burnout. So this took advantage, is an observational study that took advantage of the fact that there were 2 units where physicians were variably on 7 days or 14 days. And so they instituted a survey to ask patients at the end of, not patients, intensivists, at the end of 7 days when they were on the unit, whether they were feeling, based on fulfillment, burnout. And then they looked here and they found that after 7 days on of a 7-day rotation, about 35% said they were feeling burnt out. And when they asked people on 7 days, after 7 days of a 14-day rotation, you can see that burnout was much higher, and that was sustained even after they were, that relief of finishing, you've made it to your 14 days, that sense of burnout did not go down. And of course, when you invert that and ask about fulfillment, you get the same responses. So I think it's just, kind of, again, very preliminary data, but really as we try to figure out how to retain a workforce, thinking about these things and how we can shape the care we provide and not just have that knee-jerk reaction of, oh, we couldn't possibly go to a different model. And I'll be honest, I pushed my group up in Toronto to change from a 7 nights on straight to 3 and 4 days. And I can tell you anecdotally, I found myself more willing to engage with families when I knew I was only on for 3 or 4 days rather than 7. Because I wasn't kind of preserving myself. I could just sort of roll up my sleeves, go in, have whatever conversation I thought needed to be had, and not think, okay, well, I'm now going to have to see them for 7 days straight, and how do I sort of balance that? And talking to the nurses anecdotally, I remember them saying to me, oh, we know exactly what day you guys are on. We know when it's day 7 because we don't even bother to ask you to talk to the families because we can tell you're so sort of tired and burnt out and it's not worth it. So it was interesting to hear from them. And again, we don't have any real data on that about the perceptions from the families, from the patients, and from the nursing staff with regard to what they think of our models of care. So I would argue we need to get away from the superhero complex that we can just be on continuously and always take on more patients and do more days and not sleep, and that's okay. And this is something that I wrote about back in 2000 and have been continuing to try to provide some new data to kind of support these ideas. And this is just sort of a little diagram that tries to get at potentially what are these trade-offs and recognizing that there are definitely trade-offs on both sides. It is not all one-sided, but I do think we really need to start challenging our sort of standard models of care to figure out how we move forward in the future. So I'm going to stop there. For anyone who doesn't know, I wrote a book about the origins of intensive care in the 1950s and a polio epidemic in Copenhagen, written for the general public, in case you're interested. And I think we have a couple seconds for questions. Thank you.
Are there any questions in the audience? I think there's a microphone coming, but otherwise just talk loudly.
Thanks, Anna, for the excellent talk once again. You may disagree with me, but before we say bad things about continuity of care, we need to establish a definition. And that seems to be very difficult to say what is continuity of care. What are the indicators that we can use to measure continuity of care? And And secondly to these, maybe continuity of care for physicians and nurses is different from continuity of care on the way the family and the patient sees it. Could I have a comment from you?
Yeah, no, absolutely. And I was sort of taking as an assumption that for intensivists, continuity of care is the number of days worked, as a sort of simple measure worked in a row. As a simple measure to start with, because to your point, it can get very complicated, you know, if you're on for 24 hours versus you're on for 7 days. But I think most places, certainly in the United States, the model is about how many days in a row that you're working. Now, to your point, continuity for nurses is quite different. And, you know, but that again can be a number of days assigned to the same patient. And talking with nurses, my understanding is they have a different lens about this, that sometimes for them, they deliberately, and I don't know if this is true in every unit, but will not keep the same nurse with the same patient beyond a few days. That they've established that it's sort of better for everybody to kind of rotate people around, right? They're coming at it from a different lens. And so I appreciate that it is different for different specialties and different levels of training. What is continuity when you're, you know, a resident? That's going to be different as well. So I agree that it is going to be not the same concept, and it might be more about the shifts we've worked rather than the number of days worked for some of the specialties as well. So I appreciate your pushing to probably upfront define what I meant by continuity. I was sort of taking it more sort of this global concept as a starting point of you know, the ability to say, I know this patient, I've been taking care of them in some form for some period of time. But I agree. And I do think that the perception from patients and families is something we really don't know much about. And I was speculating in the beginning, of course, that they prefer it, but we don't know for sure.
And one more question here, thank you.
Thank you for this great presentation. So I have a question in relation to gender, and I don't know if there's any evidence on this, but in relation to outcomes that you presented, like burnout, fulfillment, so is there any evidence or data according to gender and its influence?
If there is, I'm not aware of it, and I apologize because there may be, but you know, to the point, there's not a lot of data in this area in general. Certainly, overall, surveys of burnout do tend to show a trend, or you know, that a higher rate amongst women, and that's pretty universal in kind of burnout surveys in medicine. But whether it around this particular question related to how we staff units and what we're asking people to do in terms of their schedules, whether that's a gender split, I don't actually know. It's a great question.
Fabulous. Please join me in thanking Hannah.
Thank you.
And I'd like to welcome our next speaker, Jeremy Beitler, to speak about sharing resources between ICUs.
All right, good morning, everybody. Thanks for hanging around on Friday. It's my pleasure to be here. Obviously, no disclosure is relevant to this talk. So the concept of sharing resources, I thought, was a really interesting thing to dive into, and I'd like to actually take it, I think, to start in a little bit of a different direction. So this talk is really sort of two pieces. The first is talking about physical resource sharing, which I think in the context of quality improvement, often what we're thinking about is knowledge sharing. But I would argue that the worst quality improvement or quality of care crisis we had was in part driven by physical resource sharing. So if you can imagine an anecdote, this is a recent picture of my hometown, New York City, a couple weeks ago after a big snowstorm. And I want you to think about what sort of mentality people have in their daily lives, you know, when there's a forecast for some massive snowstorm coming. And I can't speak to practice in other countries, but in the US, there's sort of a shift towards a scarcity mentality. You know, you have this hilarious thing where the milk and eggs from the grocery store and the bread all just disappear because there's some horrid event coming. And it's a very almost Darwinian survival of the fittest instinct. You know, who can arrange their schedule the best to get there first and get the resource that they need to survive the snowstorm that's going to drop a couple of inches of snow, right? It's a very perverse instinct, but it's one that I think is very common, you know, really across cultures. And that's very different then I would contrast that with an abundance mortality. When you're not in this scarcity mindset, not only are you rushing to beat that person to the store and take something off the shelf, but you're actually there willing to help people, right? You go in with the concept of, we're all in this together. Maybe one person is taller than the other and can reach an item. Oh, I have time. I'm going to help them get that last item on the shelf because I don't need it at this moment. And so I think there was a real crisis of failure to share physical resources, and that caused the worst healthcare crisis that I've ever seen. And so, not that we want to relive this experience, but I want to take you back to New York in March 2020, which was overwhelmed by COVID, right? A lot of hospitals at the time were talking about building COVID units. We were building a COVID health system, basically. So the place where I worked at the time had 3,600 inpatient beds across its health system, a total of 378 ICU beds. This was a plot of sort of the average inpatient census, including before the pandemic on the left. And then this was a plot of the COVID patients. And so you can see at the peak in March and April of 2020, our entire inpatient hospital census was replaced by COVID patients. The only way that was possible was essentially by canceling all surgeries. So basically all the surgical patients went away, everybody was an acute COVID case. But it was more dire than that. This is a plot of the number of ICU patients that were COVID positive in our health system. And the red here highlights everything that is over our health system-wide capacity. So we had over twice as many ICU patients as we did beds across, I think it was a 13 hospital health system. And along with that, the bottom plot here is the number of those patients that were on a ventilator. And you can see it's virtually 1-to-1, right? So the only patients that even got ICU status were those that were ventilator dependent. And we had double the number of ventilator dependent severe ARDS patients than we had ICU beds in normal times. And so this brought up scarcity of equipment. There were lots of dire headlines at the time around New York City not having enough ventilators. And I can tell you those headlines were very real. There were times where, there was a patient who needed to be intubated and there was not a ventilator available in the hospital. And so what happens in that context of lack of resource sharing? So, as I think happened in parts of Italy, you can adopt an approach of just manual ventilation. You literally have the family come and bag the patient until they're too tired to do it anymore. You can ration ventilators, and I think for better and worse, New York State actually had a task force and had guidelines discussing rationing of ventilators. Now I would point out that these criteria were completely ineffective because when you have all severe ARDS and everybody has the same organ failures, you're not going to discriminate by things like SOFA score because you have far more patients. So while the intent was good, it was not helpful. And then thirdly, you can think about actually sharing ventilators between patients. And this was something that we ultimately had to do at my institution. This is actually a photo of two of the first patients that we put on with the Deputy Secretary of Health and Human Services for the US government and the governor of the state of New York on the phone while the CEO of the hospital is standing outside the OR where this happened. So along with the scarcity of physical resources, I think there was very clearly across the world an issue of scarcity of staff. In New York State, they legally adopted what they refer to as crisis standards, which basically meant you're not responsible for anything that happens unless it's done completely egregiously, right? So you can be doing work that you're not qualified to do because we just need people to help any way we can. And what that looked like at our institution was we adopted a pyramidal staffing model. So I, as an intensivist, was responsible for seeing between 60 and 100 patients each day on rounds, which you can imagine makes for very effective rounds. And then we had people underneath us, so faculty physicians who were not trained intensivists, each had sort of pods that might be what a typical ICU was of 10 to 15 patients. And so I both saw the patients individually and then coordinated with the people who had a lower patient-physician ratio. Same sort of setup was used for respiratory therapists, nurses, et cetera. So what I would ask when we talk about figures like this, about the 15 million deaths that happen worldwide. I think we want to point often, so a lot of the discussion in the US, for instance, is, issues with vaccine hesitancy or people not following guidelines and this sort of tension of almost the scientific community shaming people. And I think what is completely missing from the public dialogue is the introspective look at ourselves of how much of this was due to a medical mindset of scarcity that we as a healthcare system perpetuated. And my working hypothesis for that is to just think about how, at least in the US, and I think really in Europe and in other parts of the world as well, the pandemic rolled out. It wasn't exploding everywhere all at once. What happened is there'd be a hotspot, and the hotspot would shift to a different region of the country or a different region of the continent. And so when we say a scarcity of resources, I would argue it was a completely preventable scarcity of resources, right? There's no reason that somebody from Seattle, Washington couldn't go to Nashville, Tennessee to help when there's a hotspot there if Seattle is completely quiet. Sort of similarly, you could go from Boston, Massachusetts, where there seemingly are more hospitals than patients, to rural Colorado, where maybe there's a hotspot at the time. You could go from Florida to New York when New York is a hotspot. And so the geographic isolation of this sort of periodic flare-ups of cases in different parts of the country was an opportunity missed to function as a resource-sharing network. And so I think really critically, we need a system that incentivizes resource collaboration, and otherwise I think we are destined to repeat this mistake again. When in fact you do face true scarcity, that's not just a systems-based problem, I think there are also some really difficult dialogues that we did not have during the pandemic really, and certainly not post-pandemic, that I think again set us up for conflict whenever there's another crisis. And even if there might not be a global crisis, hopefully in our lifetimes on this scale, certainly there are local crises in conflict areas and disaster areas that play out like this all the time. And so I think some of the principles to think about, when we think about autonomy, I think part of what comes into that, as a physician, you think about individual patient autonomy. But I think there's a level of autonomy that goes into allocation of community-level resources, which is a conversation that we have not had. Along with that, the concept of beneficence, trying to do the best you can, is, I think, a very complicated one. Is the goal to benefit the community versus the individual in front of you? And it's not that physicians or hospital leadership or what have you were bad actors. It's that they were operating on that scarcity mindset. I need to take care of the people in my ecosystem, not the community at large. And that leads to that rushing to the grocery store. You want the eggs and milk for your family, right? It's not that it's a bad instinct, but it might not be constructive in a scarcity environment. Non-maleficence, I think, again, is a really complicated discussion. Not doing harm, and whether that's on an individual level or community level, could provide different perspectives. And then lastly, defining what a fair distribution of benefit and burden would be. And I think, oftentimes we have conferences like this, we have a pre-conference workshop, and we decide what that should be. And I think that's a tremendous mistake, because in order for this to be effective, and in the US, the backlash of vaccines is a good example of, if you don't build community trust, you're just setting it up for conflict, right? The voices, the diversity of voices that this applies to need to be in the room. So that's the sort of physical resource sharing part. And I want to spend the second part probably on what the title of this talk was intended to be, which is on knowledge resource sharing. And so I want to start by highlighting a couple of success stories that I think are quite well established. So this is the Michigan Keystone ICU project, also known as sort of the Peter Pronovost effort, although ironically he's at Hopkins and not Michigan. But they basically conducted a multi-hospital quality improvement project aimed to decrease bloodstream infections. And we'll talk a little bit more about how they did that shortly. But they showed that they were able to significantly decrease ICU or CLABSIs, central line infections, overall across a whopping 96 ICUs amongst several hospitals in the state of Michigan. They also looked at different types of hospitals, teaching hospitals versus non-teaching hospitals, saw the same effect there. So it's not just an ivory tower phenomenon. And also small hospitals versus big hospitals, right? So even if you had a smaller footprint, maybe more limited staffing, manpower, you could achieve the same effects as what some large hospital had. There's another story of, I think, a similar efficacy in our Ontario network published in JAMA, again, quite a while ago, looking at a number of other quality improvement interventions. In this case, it was done sort of in pairs. The first was in ventilator-associated pneumonia prevention versus DVT prophylaxis. Then they had central line infections versus spontaneous breathing trials, and then decubitus ulcer prevention and early nutrition. So sort of these bundled interventions targeting altogether all 6 of these things. And the interventions at the top were all quite successful. You can see in the intervention period, the black dots there, they all trend up. And I want to highlight actually the ones on the bottom that were not effective at changing things. And I think what stands out there, and one of the lessons learned from this, is if you're already great at doing something, maybe that's not the best place to put your effort. Not that you don't need to maintain it, but how much are you going to move the needle if you're already at 99.9% compliance? So in an ideal world, yes, you'd be 100% at everything, but you want to, given limited bandwidth, you want to pick the things where you can really move the needle on the most that would have the greatest impact. I think is one of the lessons from this study. So I think sort of synthesizing this, why does networking, this sort of networking of knowledge transfer foster success? And I think, at least when I first read about those studies, a decade and a half ago, it was, there's a checklist that we need to implement. And I think that was sort of a gross bastardization of what it really was. It was really a behavioral intervention. Trying to change physician behavior, some of the most obstinate people possible, and nursing behavior in the ICU. And so a couple of the things that they did that I think were quite successful. One is central coordination, ideally by an extra-political entity. When you have hospitals working together or ICUs working together, there will be politics, especially if you have sort of the lead hospital of your health system telling the others how to do it. That is not the bidirectional transfer of knowledge that will maximize efficacy of the network. I think having local physician champions, local clinician champions is critical. That was a common theme amongst the 2 studies and several others. In particular, because then you can have peer-to-peer communication. And so it's not just having a physician champion, it's who will your intervention touch? Is it physicians, nurses, respiratory therapists, pharmacists, et cetera, and making sure that there's peer-to-peer dialogue on whatever level of staffing it is. Ensuring that there's regular communication scheduled is critically important. Benchmarking, so having data collection is critically important. And I think it's in part to overcome dogma. We all think that we care for the sickest patients and the data don't apply to us. So when you put peer institutions that look just like you and they're doing better at something, that's motivating. Having both friendly competition and group-wide victories, I think is quite effective. And then lastly, the goal of these networks is bi-directional sharing of lessons learned. The communication needs to be across the whole network in order for them to have maximal impact. So in conclusion, there's issues, I think, of both physical and knowledge resources. And in both cases, the answer is network-based sharing. There's a psychological barrier of this scarcity mindset that we have as individuals that's ingrained in our health system. And I think we have not tackled that, which sets us up for failure again. In addition, there's the knowledge network-based sharing piece. And I think these quality improvement interventions, the fact that they were done in a network, the fact that they were a multi-center trial, for instance, it's not that that makes them more rigorous. That was actually part of the intervention itself, was the multi-center nature of it. The differences in perspectives and the knowledge sharing that happens. And that helps to overcome sort of the groupthink barrier because you learn from others ways that they can effectively do stuff. And no matter how great your hospital is, you're not the best at everything, and peers will be better at something. And so there's an opportunity to learn from each other that I think requires an openness. And so I'll end by saying that a collaborative network of ICUs working together will definitely achieve better outcomes faster than if they were working alone on the same initiative. Thank you.
Only time for one short questions. Only one question. Have any question? No? Then may I ask a question? And What are the best way to share the ICU personnel and equipment across different hospitals, you think? Yeah?
I'm sorry, what was the first part of that? What's
Yeah,
the?
the best way to share ICU personnel and equipment between hospitals.
Yeah, I think there's probably a couple levels to that. I would imagine there's the informal, if you will, sort of organic networks of hospitals or health systems that agree to operate in a certain way. And I think that can be effective in cases of limited scarcity. If there's, I guess using the weather example, if there's a tornado that, is going to affect a very small space but won't touch your hospital, I think that kind of agreement will facilitate the transfer of resources. But I do think there is a role for higher level, almost mandating of resource allocation. Somebody needs to be responsible for the bigger picture. And I think that's, in settings of widespread crisis, that's really the only way that there will be a effective overcoming of the bias towards a scarcity mindset.
Okay, thanks again,
Sure, thank you.
Jeremy. And we switch to our next speaker. It's Jose Alsar, and the topic is the best quality indicators.
So, good morning. Thank you for the introduction. My task is to talk about best quality of care indicators. And I decided to start by saying what indicators are not. So, indicators are not the actual reality, just like Magritte's painting on the pipe painting show us. They are just a reflection of the reality. But they have to comply with certain purposes. They have to be smart. They have to be specific, target a specific area for improvement. They have to be measurable, quantify or at least suggest an indicator of progress. They have to be attainable, and attainable given the resources that you have in your ICU or service. They have to be relevant, be about determinants of outcome, and they have to be timed. They have to specify when the result should and can be achieved. Of course, this acronym, SMART, may be used several ways, as you can see. And another characteristic that indicators have to have is they have to be agreed upon. I mean, you don't decide the right indicators for the ICU you're going to help or assess or improve. You have to consensualize the indicators with the health care staff of the ICU. They have to matter to them. Donabedian has divided indicators very smartly into structure, meaning the context, process, meaning the actions and interactions that are established, and outcome. So there are health needs, you mix structure and processes, and you deliver an output, which is the outcomes. And indicators have to cover these three different areas. And they should also cover the 6 dimensions of health quality as defined by the Institute of Medicine. Allow me to remind you: safety, effectiveness, efficiency, patient-centeredness, timeliness, and equity. These 6 dimensions are important and have to be covered by the indicators. The indicators have to respect some characteristics, and I decided to talk about 3 of them. Validity and reliability. There are things that are often confused, and I try to summarize in that figure over there on your right. High validity on your right, high reliability in the bottom. So validity determines how accurately an indicator measures the intended construct or phenomenon that you want to measure. And reliability indicates the consistency and stability of the measurement. So 2 different things, although a valid indicator is often or most often reliable. The opposite is not true. And the other characteristic is feasibility. Is it pragmatical? Is it practical? It is easily attainable to get the indicators. And when you decide about the indicator that you want to provide and build, you have to build and reflect on a good bisectrix between validity or exhaustivity and feasibility. To put up an indicator, you should build an anatomy or ID of the indicator. This is important because without this, people will not understand the indicator. And this means explaining the purpose of the indicator. Of course, being very clear the type in terms of Donabanian structure, process, or outcome, and the dimension in terms of Institute of Medicine. And then very important is to clearly establish the population and the formula for obtaining the indicator. The time period that you're going to assess, is that monthly or trimestrally? The source that you're going to use, and very important to be very clear and consensualize the standard and the target. The standard where you should be at the moment, and the target where you are aiming to be. And afterwards, something that is often forgotten, the visualization of the indicator is very, very important for the understandability of the indicator. Finally, a word of caution about what is called Goodhart's law is that a measure is not the target. Okay, so you have to use paired indicators and several indicators and somehow use balanced indicators. Let me give you an example. You cannot interpret your rate of reintubation after elective extubation without assessing the rate of unplanned extubation in your ICU. So you have to balance these indicators, or if you want to decrease cephalosprins, for instance, for treatment of severe community-acquired pneumonia, you don't want with that to increase the use of piperacillin, tazobactam, or carbapenem. So you need to balance indicators in order to perform a good assessment. But probably the most important part is know that if you can't measure, you can't improve. That's true. But the only reason to measure is to improve. So the purpose of indicators is to act, to change, okay? Don Berwick has said very clearly, I'm not interested in measurement per se, I'm obsessed by improvement and the role of measurement as in that process. So measurement is not the goal is improvement. And so the difficult part, in my experience, is to be able to build this learning health system. The difficult part is to be able to go easily with high feasibility from data, loads of data in your ICU, analyze data, create indicators, provide knowledge, and then take knowledge to practices. As you know, it takes usually 7 years to take evidence-based knowledge to practice. So this learning health system is very difficult, but it makes us clear that data needs to go to indicator, to knowledge, and then to action. And then you analyze your current performance of care. You know where is your quality control zone, as you can see there. You analyze it. You analyze the factors that influence the provision of care and the outcome, and then you build a quality improvement initiative or intervention in order to improve and then create and sustain a new quality control area, okay? So this is the purpose of the indicators, and you can only do it by having this dynamic measurement of the indicators, preferably annotating the timing of your interventions to relate them with the change of your quality control zone and provide constant feedback to the ICU staff and the ICU providers. So this is paramount. And please remember that systems and goals are different. So if you improve a certain indicator to your target or to your goal, you really have to put the things that led to the improvement into your infrastructure. Otherwise, you will fall to the level of your system and the goal, the target, will soon disappear. So the last question is, which ICU quality of care indicators should be selected? Usually the last question is the most difficult one, and this is the case once again. So it all started, for me at least, with Peter Pronovost again in the US, that selected a group of indicators that should be measured constantly. And then our European Society of Intensive Care, a lot of time ago, that was 2012, defined another group of indicators with the Donabedian mantra of structure, process, and outcome. But if you look at them, it's very clear. Only above 90% were selected for the panel of indicators. If you look at them, process indicators are only, I guess, 2. And structure and outcome indicators predominate. And that, in my opinion, the case is that if you put together experts from different countries, different continents, different experiences, they much more agree on structure and outcomes than on processes, because the processes are more different from country to country and from region to region. And therefore, there's a scarcity, I would say, of process indicators in the European Society mantra of quality indicators. When you move to country indicators or European Countries Society of Intensive Care indicators, several examples. The Netherlands, you can see here, with a very good balance between structure and process and outcome, although you may discuss if all these process indicators are really process indicators. And they not only have developed indicators for each ICU, they have also developed indicators for network ICU, for regionalized critical care performance, which is very important because that's one of the areas that we want to emphasize. Remember the domains of quality: equity. Equity can only be assessed with regionalized indicators. The Spanish Society, a very long time ago, and updated in 2017, 25 selected top indicators for ICU. The Germans have also developed the quality indicators, a very, not many, 10. And again, when you look at it, a predomination of process indicators: management of sedation, patient-adapted ventilation, early weaning, infection management measures, patient-adapted clinical nutrition. So a lot of process indicators, which in my opinion is a good thing. And we in the Portuguese Society have also developed the top 25 indicators that we're trying to implement now in the collaboration between intensive care services and mainly trying to provide the learning health system, establishing a high feasibility of going from data to the indicators. So globally, I may summarize that there are 2 good things, in my opinion. We're moving from a mostly structure and outcomes indicator into a more balance between structure and outcomes and processes, and we're understanding that to have better outcomes you need to assess processes and act on them to improve them. And on the other hand, we're moving from staff-centered indicators into patient and family-centered indicators and incorporating PROMs and PREMs much more often than we did before. But the question is, which is the best set of indicators? I'm afraid to say that we really don't know. I mean, there's a lot of things going on that I tried to summarize there, but the true thing is that in summary, the medical literature does not support the superiority of any one indicator set against another indicator set, and that effectiveness depends on local context, implementation fidelity, and integration into quality improvement processes. So, and also that we need different kinds of indicators. That's another very clear evidence-based mantra, which is we do need not many, but several indicators. We may discuss that maybe the ones that are most consensual and that you can find in several societies' proposals are the ones that I put here in yellow: standardized mortality ratio, readmission ratio, ICU length of stay, several areas of process compliance that we know are related to better outcome, and in terms of structure, the availability permanently of a consultant-level intensivist, and meeting standards for resource allocation and reporting and PROMs and PREMs. But if I have to counsel you on this, I would say it's very important that you draw on a piece of paper or your computer, of course, depends on your age, a kind of this mantra. I mean, structure, process, and outcome. And then the domains of quality on the other hand. And it's important for me that you are able to cover all or almost all of these areas to design the indicators. I did that exercise yesterday, trying to fill some of these areas. But please do not forget the ones that are most often forgotten: patient-centeredness, timeliness, and equity. And again, for equity, as I told you, you need a regionalized network, regionalized indicators. That is clearly very, very important. So, to summarize, I would say that we should use indicators to cover the 6 domains of quality and to cover the Donabellian mantra of structure, process, and outcome. Before you give them to anyone, please draw the ID of each of the indicators. Do not use only one indicator to assess anything. Balanced indicators are important, and combination of indicators is fundamental to obtain better information. The difficult part is probably you have to create a learning system to allow a swift path from data to knowledge and from knowledge to practice. And indicators are really for this, to link data to change and to promote improvement. And please do not forget PROMs and PREMs, and aim at the system, not only at the goal, because without aiming at the system, you will fall from the quality of the goal to the quality of the system. Feedback and dynamic measurement are fundamental. No set is superior to another, but there's clear evidence that indicators and feedback of indicators are able to promote and boost and leverage quality improvement in your services. Thank you very much.
Thank you so much. We probably have time for one quick question, just up the back here.
Thank you for the very provocative talk. My question is, are we becoming better at quality? Huh? Oh. Are we getting better at quality, or are we getting better at fooling systems with metrics?
I think we are improving in terms of intensive care delivery, yes. But again, to know if we are improvement, we need to create the measurement system. For me, the right answer to your question is that if you don't measure, you can't improve. But the only reason to measure is to improve. These two things are fundamental. And again, they align what clinicians and managers want. Okay, so Now, for me, another sub-product, if you want, of indicators is this alignment between clinicians and managers in terms of purposes. So we need to measure to improve, but the only reason of measuring, as you say, is improving. I believe that most systems are improving, and as we've heard, the experience from the pandemic, in most of the countries, I would say that the resilience of the system was fantastic in terms of intensive care.
Thank you so much. Our next speaker is Vitaly Harasovic. I'm speaking on ICU reports, what should be on the dashboard.
Hello everyone, and thank you to staying Friday. That's always last day, always difficult, yeah, to pay attention, I would say, and so on. And in my talk, I actually, yeah, we have great overlap what Dr. Paiva previously told, and but I would probably focus more on the kind of implementation side of that and how computers, electronic medical records can help achieve these metrics. Again, the quote what you just saw like 10 minutes ago, if we cannot measure, we cannot improve it. But really just very simple question, why we need any kind of the reports? And probably the most important piece is the practice needs. We need this for a practice. It's very well documented what quality measurement has ability to improve quality of care delivered by providers. But second, it's a regulatory requirement, and obviously this is very different in different parts of the world. In the United States, a lot quality measurements needed for accreditation and licensing, and number of these requirements, it's only grow. Like the quantity of the performance metrics, it's big, and obviously it's the resources to get this data out of the environment, packaged in a format would require it and send this to agency. But this is old case. This is 2004. Is it really metrics matters? And what metrics it matters? Former US President Bill Clinton had cardiac surgery, bypass surgery in 2004. And his selection of the hospital where he got surgery was kind of the strange from the number, from the metrics, from reports or so. He actually had surgery in a hospital which has highest death rates for this kind of the surgery in state of New York. All 35 hospitals in state New York who perform surgery, they have better mortality rate. And he went to the hospital with worse mortality rate. Let's end up with something like that. Like, you know, we get a great metric, like, you know, like this. Your cat rank ahead of your boss. I mean, great metric, but it's really does change decision. I mean, we have these numbers, and is this numbers matters or so? And does it actionable? Some metrics, they are great, but we have nothing to do to change these numbers or so. As previously speaking, quality of care usually estimated in a structure, process, and outcome. But a lot of metrics describe these domains, often poorly defined or difficult to measure. It's simply difficult to get quality data. And a lot what we have done in manual process is very subjective. And obviously, patient-centered outcome of interest. And this is very different from the regulatory requirement, which try to blend it with this type of the metrics. But better care, better health, and lower cost. We want to provide better care. We want patients to have better health, and we want to do this with less resources. As simple as it is, 3 groups of the matrix. From our experience, like in 2009, we end up in a position what we need to have this matrix. And our leadership with conversation with providers and so, again, a regulatory requirement, we defined this 11 metrics at that time. And for almost a decade, we use computers which pull data out of the environment, calculate these metrics. But instead doing any fancy stuff, we just print PDFs. PDFs, it's nice because it could be printed, it could be on your table, always available, and readable without anything what could be kind of slicer, dicer, and extra clicks. And these reports, we provide monthly reports, ad hoc reports, and also like little bit customization. But that's the experience what was almost 10 years, 20 years ago when it started. And we published this in the literature. And a lot of put into this metrics. This is one of the example, 28K performance indicators, which was developed by Delphi process in one of the hospital. And again, they kind of like tied to the structure, process, and outcome domains. But can computers help us to do these metrics more efficiently? And obviously, as we get like electronic medical record everywhere, we probably can utilize this opportunity. First, it's allow us to use clinical data, not administrative. Any administrative data, it's a summary data, summary of the clinical data, another subset. It's kind of like non-parametric statistic derived from parametric statistic, which sometimes lose signal. Computation, computers can do this easily in a fast way without 24/7. And ability to send feedback to provider. As I mentioned, PDF reports nice to great on the table, but get it in a right time, right place, to be actionable. It's one of the points which cannot be done on the paper. And from technicality standpoint, there are a couple solutions. Obviously, this is manual IT reports, what we can do traditional way. They not very young, not very speedy, I would say. They have delays. Accuracy maybe vary because this is manual process, people make errors. And flexibility, it's also based on the resources. You need more human resources to develop it. I mean, it seems like a third-party reports could be something what tend to be like easy solution. All great. The only benefit, because that would be probably standardized, validated in a way what's done for some agency reports or so, but you tied for vendors. And as soon as you done, without any additional payment, you tied for wherever you purchase. And custom data marts and some tool like a Tableau, for example, they would be very appealing to have this all custom reports. But going away from the vendors probably is right movement, which required at some point like a little bit more effort, but it pay off in a long run. Technically, yeah, we need to get some interface because now we're going to make this on the computers. Single screen view, it's a great way to do. Again, we tend to have this multiple screen environments, which looks nice on the pictures, but this is, at the end of the day, it's difficult to manage. You need to have something on the single screen. Simplify, simplify, simplify for graphics format. No fancy stuff. And this, in past decade, we have like a lot this usability improvements over the years, but simple graphic formats. we need to highlight key thresholds, really highlight something what important and draw attention, and eliminate this data redundancy, because first we need to get this from a clinical environment, not administrative, and again, remove something from the view which does not directly support clinical intervention. If metric, nice, but cannot change anything, probably it's not something what we need to have on this very first screen. This is an example of the dashboard which we made available for a practice in 2014. Every block represents one of the ICU at Mayo Clinic Rochester. And the beauty of this report, it was real time. In real time, you can see beds utilization. In real time, you can see how many patients on the ventilator, how many patients have vasopressor support, and so on and so on. When you click, you can drill down to more details when you get this type of the metrics what I mentioned previously, kind of metrics which matters. But important to understand, this type of the dashboard need to be role-based, custom, no single shoes for everyone. And for a clinician view, for attending view, these metrics need to be more focused on the clinical parameters, I would say. For nurses, administrators view, it's more need to be operational, like these beds, capacities, and so on, and so on, and so on. In this 2014, that was our first attempt to blend these efforts. And again, on the top, you can see number of the patient on the ventilators, which nicely show resource utilization, and also could be indicator of the workload and severity of the patients, and so. I mean, but what we learn, it still need to be a role-based customization. And this is more recent effort, and obviously it's a lot of information there, but it's designed for this like 4K screen sitting in front of you. Custom real-time operational report for what we have after COVID role critical care officer of the day. There are a couple group of the metrics, and on the left, because this is particular example, it's a surgical ICU. There are real-time information about procedures when patients coming. On the middle, you see indicators of the organ and kind of like severity of the patients. And on the right, there are some metrics and like what people call AI these days. Some prediction models show different type of the metrics and possible scenarios or so. But that's a more modern days type of the infrastructure. What is the anatomy of the perfect clinical reports in command center? First, that need to be this automated data pools. It's important. Again, no manual data entry. As soon as we have a human in a loop, that would be delays and so all automatics. And any type of the abnormalities need to be color-coded, like spikes, something would draw attention, need to be there. And also, like first layer, it's not everything what you need. Ability to drill down and get more details, answer to some questions in more kind of like more details which hide from the first level. And categorized by this key performance metrics indicator and as we talk structure, process, and outcome, and so on. And going mobile, why? Because some of these metrics, they matters in real time. As we move more and more to this mobile solution, it's probably not a bad idea to try that. Because that gives ability to continuous patient tracking, everything close to real time. I mean, in the past we have these notepads, but iPads replace a lot workload these days. It's another element. And to conclude, we need to have this integrated reporting dashboards, which would be have like precision scoring, actionable safety in surveillance, again, real time, optimized for humans, nice user interface, and so on. Obviously, move from the paper to the digital would be a logical next step. This is my last slide, and this is our applied clinical informatics laboratory at Mayo. Thank you.
Thank you. Any questions? Okay,
Yes, in the back.
Thank you. It's a great presentation. What sort of capability you need to build within your intensive care unit for making this happen? For example, do you have data analysts, integration specialists, et cetera, et cetera?
Yeah, that's a good question. Obviously, if there are no data, there are no dashboards. Data need to be available one or another way, through the electronic medical record, I would say. And person who be able to crunch this data, it could be data analyst or so, but our experience show what, because their clinical knowledge is needed. And a lot of this report was built because we have in a lab like physicians who trained and looking for like year or two of the research and spend time. They understand data, they understand information behind it. I would say partnership between clinical specialist and IT person, it's a must. How you balance that's depend on your available resources. But IT itself, very difficult to build proper metrics without clinical input.
Okay, thanks again. And it's for the time we should speak to our next speaker. It's a Jonna Berger athlete, and the topic is education should be present everywhere.
You're leaving now? Okay, so I'll try to make this quick and easy. Obviously, I can't tell you everything about education in 15 minutes, but I will do my best. So these are my conflicts of interest. They will not interfere with what I have to tell you today. So why do we talk about education in the ICU? The ICU is, in my point of view, a place where you have so many opportunities to learn. It's a complex environment. There's a lot of bleeps, a lot of curves, a lot of lab work. There's also rapid decision making that we have to take, and we have to learn that. We have to teach that to our colleagues. But we do have multidisciplinary teams, and sometimes things can go awfully wrong or awfully fast, and maybe that's not the place where you would think that it would be a teaching method. So there are several aspects that you think, well, maybe the ICU is not really the place to teach anything to anyone. We have even an anti-educational environment. Mistakes are quite immediate. If you change drugs or if you switch a syringe or anything, you have an immediate serious consequence. There's a lot of stuff going on at the same time, so there's a lot of what we call cognitive load. So that's not really good for learning. You have to learn sort of like bite-size something first and then integrate further. So it's hard to process new information. And imagine you're at 2 a.m. and someone has a code. That's not the correct time to give someone a 20-minute lecture on resuscitation. So we do have to sort of tackle these issues and see how we can go around it in a way that is good for everyone. So Professor Paiva knows that I usually wander around the room, and this is not going to be any different. So if you look at that picture over there, what strikes you as unusual? That could have been an ICU in the 1950s.
Unusual? What is the unusual on this picture?
Or do you think it's all very normal?
overly normal discussion about the patient, just a team, a big team.
Okay. So there's conversations going on. Hilda, what do you think? Do you think that this is something that we could reproduce today?
Hopefully not. It looks like the patient is not engaged.
Okay, that's true. Everybody's looking at the patient, talking about the patient. Oh, you want to participate?
Yeah, that's poor infection control.
Yeah. Okay, good, very good. What about you?
No any equipment beside the patients.
Okay, but I do see young men, mostly men, a nurse, someone with an X-ray over there on the hand. And so infection control is not really something, but and we see what we call the apprentice model, which is how some of us have learned medicine throughout the years, which is there's someone with a broad range of knowledge that is explaining something to a group of people. This is not possible nowadays for many reasons, but particularly because, for example, we as clinicians, we do not have the breadth of knowledge that our ancestors or that the people before us had. We are very specialized now, so our breadth of knowledge is very narrow. So what we pass on is also very narrow. Then we have difficulty in supervising, because in such a complex environment as the ICU, it is impossible to keep track of 20 students like that. So it's not feasible. Then we also have a learning environment that is no longer just a nurse in the background. Nurses in the ICU are a very important part of the complexity of treatment and of care, and therefore they need to be involved. And then, I'm not sure how many of you teach in a university? Hands raised? Okay, how many students do you have per year? Around 300, 400, 500 medical students, not the 20 that we show there. So it's not possible. Those models, those traditional models cannot be, we cannot do it anymore in the ICU. And then there's another aspect which is relevant, which is everyone has a different type of learning. Some of us like to learn visually. We like graphs, we like images, but others, we like to learn by doing audio, audiobooks, podcasts, or something like that. Or some of us like learning by doing, like kinesthetics. So I would prefer to learn how to place a central line if I have someone next to me telling me exactly what to do. This will help me better than watching a video. And obviously, every one of us has different learning styles, but we also change our learning styles during our time. We may start by liking visuals, but then evolve to audios or kinesthetic. So this is all very fluid. Oh, sorry. And finally, we have this conception as teachers in the ICU that our students are like students in the classroom, and this is not the case. We are teaching adults, and we as adults, who are also lifelong learners, we learn differently. We learn motivationally. We learn that something that needs to be a life or a problem-centered problem. We learn actively. It's not like in a classroom with 5-year-olds where you're teaching the rivers and the mountains, and it's a very passive and determined way of learning. For us, it has to be built on prior knowledge and meaningful. And this is called self-directed learning. This is one area that I really like to investigate, and this is basically what we should do as learners in healthcare. Learners and teachers, so we should embrace self-directed learning. And what is it? Well, it's very simple. We identify learning needs. We then set goals to ourselves. Let's say, oh, I'm so bad and I am so stressed every time I need to intubate a patient in the ICU. How can I do to improve this? So I set my goal, I choose my strategy, what can I do? I can take a simulation course, I can take a mentor in the ICU, I can have a lot of strategies, read books, probably not, but guidelines will help. And then I will implement my learning and see how well I did. And this is self-directed. An important thing about self-directed learning is that it's learner-driven, so you decide which goals you need to achieve, but it doesn't mean that it's self-learning. It's self-directed, but it's not self-learning. So there is a lot of help needed going on when you self-direct. You need a mentor, you need an interprofessional team. So this is not necessarily just an alone thing, something that you do alone. And we've looked at all the things around, all the factors in healthcare influencing self-directed learning. This is not specific to ICU because the literature in ICU is very, very, very slim. But if you think of it, what are the things that make you, as an adult, learn better? And now I'm going to go this way. Oh, let's take our moderators and ask them.
What helped me learn better? Yes. I think for me it's being particularly interested in the thing I want to learn about.
Okay, so that's about the promoting factors over there. Personal factors, process factors, contextual factors, so things that depend on you, about your personal interests. But there's a lot of stuff there that is about stuff that happens around you that doesn't necessarily have to do with you. Antonio?
I think if I feel that everybody around me are also motivated to learn, so this interaction, I think it favors.
Okay, that puts me on a very interesting thing, which is the informal learning. So how many of you learn with your peers? You go to a coffee together, you discuss a complication, and you have a huge amount of information just by that small interaction. So the socialization of learning in the ICU is very important. So please do not delete or do not take away the coffee rooms. It's very important for many things, but also in learning. And another thing that I find particularly important, and that's been discussed often here, is the importance of accessing information or digital tools. We are now in an era that is like bite-size, so we need to access information all the time. So having tools like Copilot or AI around will help us a lot in decision making. And all of this is, so Professor Paiva knows these two slides already. And another thing that is important that I want you to consider is the aspect of generations. So just take a look and see where you fit in this room, in this slide. Where is it that you fit? And then let's take an example. So Professor Paiva is the head of department, I know. Are there any other heads of department here? No, okay. So let's just take a look at this example. If you want to speak to someone pre-war, you better write them a letter, because that's the best way to get their attention. But if you're a baby boomer, maybe you just give him a call at his phone, at home. He still has one. And then, but if you're Generation X, you can go along with sending them an SMS or a text or an email, and that will work. But if you're Y, it will work better if you use some sort of social media. You contact them via LinkedIn or WhatsApp, and that will be much more adequate for them. They will prefer that to anything else. And the newer generations that are coming will prefer more and more things that are related to AI or technology. And this has a huge reflection in education. So when you're educating someone that is a boomer, you will probably want to give them lots of information, a booklet, and probably something in the end like a certificate. They will love that. But if you're a Gen Z, you would want something that is a bit more case-based approach, some real-world feel, and then give them some additional resources to look at home when they're gone. If you're a millennial, you have a very short attention span, so you better do something which is bite-sized, which is clustered. And as you move on, you will have more and more things related to gamification and learning with technology. To the point that some of you in the room will have children that will learn or are already learning like this. They learn about games and they have hybrid environments. So this is the future. And this is the future also in the ICU. In the ICU, what we have is from the classroom to everywhere. So the just-in-time. Just-in-time, why? Because you can't really schedule any kind of learning event in the ICU. You are continuously learning. So you have to have an information that is available every time that you need it. So it's learning while working. And this has been shown in literature that is it's more effective in learning when you learn very close to the event that you have taken than actually having a span or a gap. So how many of you know Life in the Fast Lane? Good. For those who don't, I don't have any shares or anything in Life in the Fast Lane, but it's a very, very good, for intensivists, a very, very good resource. We can have quick updates, you have the new trials that are summarized, so it's really good. And this is something, for example, that you can exemplifies the concept of micro-learning, like you learn very fast, you have this educational snack every now and then, you have videos, infographics that can help you. This is something that is very practical nowadays. Now, another thing that can help is simulation. We all know about this, and this is why I put simulation 2.0, because we need to be somehow proficient in in-situ simulation or simulation with VR, which is coming up. And finally, all of us will have to have some sort of practical literacy in AI. And this is something that Professor Van Sam picked up, and they have even suggested in this conference an AI literacy course for intensive care. If you don't have any other literacy things, you can sort of try yourself, but it's important to have some sort of literacy. And this is my last slide, right on time. So if you have no idea of what AI or technology-enhanced learning is, this is a very good summary. So you have purely digital education where there's no, there's only a digital realm, there's nothing physical. And then you have the aspects of or hybrid or blended learning, which you mix the digital with the traditional, and you have a series of things that you can give to your students. So the conclusions of this is, if you have to prepare anything in the ICU, try to use a different sets of learning strategies, because not everyone learns the same way. Then potentiate anything that is self-directed. Ask questions and give the opportunity for the trainees to look for themselves, but with your help. And finally, for yourselves, digitalize, because what is coming here, what is coming next is a full digital world. Thank you so much.
Thank you so much. Any questions in the audience? At the back here, thank you.
Thank you for this very interesting presentation. I'm from the Medical University Vienna, Pediatric Intensive Care. We recently...
Where are you?
At the back.
Ah, okay.
Here.
Hi. Okay.
Hi. We recently implemented a scalable, evidence-based education model or framework, and we're looking for a metric to evaluate it. Do you have recommendations?
Yes, but we can talk about it later.
Thank you.
Are there any other questions in the audience? I might just ask one quick question, if that's okay.
Sure.
So, you know, primary school, secondary school, the teachers there are taught how to teach. And yet then when we go to university, you have people who are experts in the area they're teaching, but they've never been taught how to teach. I just wondered your thoughts on that, and the fact that we don't require people outside of teaching our children to actually become educated in how to teach.
That's true. And you're now touching a very sensitive, spot, which is, I think this comes from the Hippocratic Oath, because we are supposed to teach our younger generations. This is what we do when we finish school. We swear that we're going to do that. But the thing is, we have absolutely or very little, unless for a personal trait or characteristic, we have no training whatsoever. So this is why I can only suggest to everyone in the room who is interested in teaching that they do one of the many Masters of Medical Education spread around the world, because this will give you, it's a 3-year course, it will give you the basics in psychology of education, which is a thing that people think, oh, there's no p-value there, so I don't want to do it. But it's really important to learn how to teach. So for those interested, I would highly recommend.
Thank you so much. I'd like to now welcome our next speaker, Victoria Metaxa, speaking on focus on the person, not the disease.
All right. Thanks very, very much. So I'm going to talk to you about this topic that patient-centered care has been recognized as integral for health delivery for a few decades now. So I kind of thought that instead of saying things that I'm sure we all agree and we know that they're really important, whether I would welcome you and maybe try and challenge you to things that I find challenging about a topic or a concept that otherwise should be very clear-cut. I've got no conflict of interest, clearly. So this is what we're talking about, and these are some publications throughout the last few decades about the importance of patient-centered care. And that started around 1993, so it's not like forever, around 1993 from the Pickers Institute in New York. And that was as a response to the concerns that were raised, that the care was more about the disease and more focused on the clinician rather than the patient. So we then started talking about patient-centered care. And the whole idea around this is the fact that, it needs to be, the care we deliver needs to be tailored to the needs and the wishes and the preferences of the patient. It becomes a little bit more difficult in ICU, of course, because all our patients or the majority of patients are asleep or incapacitated. So that's when family-centered care started coming into it. And this family and patient as an entity, as a continuum, started getting into this. And these are some definitions that are out there, as I said, is fully endorsed almost by all, I think, critical care societies in the world. And these concepts, these ideas, are being used interchangeably almost, family-centered care, you see. I've highlighted some words that keep coming up and up and up, some notions that keep coming up, like respect, and how it is, again, respect in the patient-centered care, about in the shared decision-making, how we can come along with the patients, or the families and the patients come together and they need to be included together. The thing that slightly stands aside is probably humanization. And I want you to see that the difference in humanizing critical care is something different than patient-centered care, is because it invites us in the equation as well. So clinicians are being considered as well. So think this, and let's focus on some of the things that, some of the words that keep being repeated and repeated. And this is respect and dignity. And I don't really think that anyone would argue here that, we need to be respectful towards our patients, and patients need to be, their dignity needs to be respected. And this is where something starts, I start having difficulties with this, is because of what exactly is respect? So this is a very nice article published a while ago now in the Blue Journal that said that respect and dignity are these two notions that are intertwined, and it is very clear, because respect is about the actions we do against our patients, and of course if we acknowledge that they are dignified human beings, and the definition of dignity is this intrinsic human worth. Of course they need dignity, because being human worths dignity. And then very clearly, very simply, they say, there are some barriers and there are some obstacles there. And look, if they're altered consciousness and so on and so forth. And it is so simple that they give us, and not just them, some examples of disrespect. And you can read them here, and you say, just please, just don't do that. And then everything will be respectful. And I agree. It's basic, I think, good manners to, if someone is awake and you go into their room, to knock on their door and say hello to them before you even touch them. But look about further down, I don't know if you can see it, about, talking to people that are completely out of it or completely incapacitated. And what happens if, they're so heavily sedated they'll never know you're there? And what happens if you don't even have a room or a door to knock? Does that make you disrespectful? And what about this? So what about, not talking about room 5 just had a heart attack, or the cholecystectomy just arrived, they have complications. So this is a sign of disrespect. But is it really? And is it always? So you can see here that I could only master 3 publications on the topic versus the millions of publications on the patient-centered care. But I find them very interesting, because they do argue that, we may not be disrespectful when we try to distance ourselves from our patients. It might be a protective mechanism. And people did do that during COVID when they were talking about the disease as a maybe unconscious way of distancing themselves from their patients, from the patient's pain, from the family's pain. And what about the publication down there about the ethnographic study is quite interesting as well. It talks about nurses and the fact that there's such a discrepancy between what they do, and they do talk about, the drugs for 5 and let's, turn number 7. And when they're being asked, they think that the way they refer to their patients is disrespectful. And that this dissonance between what they should be doing, always about the patient, and what they're actually doing, that might serve a purpose, right? It might serve a purpose of handover, of brevity, of exchanging information. That increases their moral distress. Like we've ingrained that that's a wrong thing to do, and yet we do it. So, I wonder about how disrespectful it is, and whether it is really dehumanizing our patients in every situation. But let's go to talk about dignity now. And I do really love dignity as a notion. And I'm pretty sure if you are like me and you're having a ward round, there's invariably someone that will come to you and say, really? Really? That's undignified now. And it's undignified, and what people find undignified, it could be anything, by, doing CPR, or, leaving the door open, or invariably almost is about continuing life-sustaining treatment. But here's the thing about dignity. Dignity has been around since forever, but it meant very different things. So in the Roman times, you couldn't be dignified unless you were a noble. By definition, not everybody had this inherent dignity. And then in the Christian times, only people that were made in the face of God were dignified. And that strikes away almost immediately anyone that was disfigured or not normal in any way. The dignity that you and I are more accustomed to is, it emerged, that kind of idea emerged in the 80s. So it's not forever. And it started because around discussions about the process of dying and the desire to avoid burdensome and life-prolonging treatments that all of a sudden were named, or maybe progressively, were named undignified. And there are always some religious connotations about dignity, but you can see that there are ethicists that, dare to provoke this. And clearly this is not going to be very boring and very prolonged and very ethical-like. But I would like you to know that there is no actual single definition of dignity. There are plenty. And that clearly always constitutes a problem, because I always say that we've somehow managed to find a single definition of ARDS, of a thing that doesn't really exist. But yet there is one definition. But there is no definition of dignity. So there's this basic absolute dignity, and you saw that in the previous slide, this inherent dignity that we all carry as human beings. But that doesn't change by the fact that we can mentate, talk, be intubated, or in a minimal conscious state, because that doesn't change our absolute dignity. That stays like this. What changes is our personal dignity, a different type of dignity that is more individual and more transient. And that can change because it is described and it is defined by me. If I think I'm dignified as I am, and all of a sudden I lose a leg, or I don't know, my hair falls out, whatever, then by me, I now describe myself as undignified. And that might change. My definition of my dignity may and will change whether I'm 20, 60, or 85. But then to confuse this even more, we have relational dignity, and the relational dignity springs from the relationships we have with other people around us. So maybe I'm dignified because I'm the breadwinner of my house, and I take care of everybody. But when something happens to me, and then I think that I'm going to be a burden to everybody else, then, and there is quite a bit of literature about this, right? And there's the conversation about euthanasia and assisted dying, and whether people are led to this, are driven to this because they feel they are burdened to others. And when we say this, that's the dignity that's being violated, our own perception of relational dignity. And Kantian dignity only exists if you are autonomous. So basically, the moment you're intubated in ICU, you are undignified. I'm just trying to say that the next time that someone says, let's admit them, or let's do CPR, and then you say, oh no, that will violate their dignity. Please remember, or please be certain which dignity you're talking about. And that's, yeah, I mean, I love that because, you know, we use this to base our arguments against, and clearly those arguments the idea of dignity has been used by pro-life groups and also from you know, pro-autonomy and quality of life groups, which is always a mystery to me. And then what about dignity, and what about end of life, and what about, you know, patient-centered care around death? That speaks very important, you know, it speaks to the heart of all of us. That's why we're doing this job. But what I really find important, and this is great, this is a systematic review about a good death, yes, and what it means to have a good death. And you might think you know, but again, this is something that has changed through the years and through the centuries and with the emergence of palliative care. And then you see that the literature and the Central, Northern European, North American literature, which is the literature we have, unfortunately, focuses on the place that the death occurs, the means to one's death, so whether we choose our death or not, whether we decide and we are involved in the decisions. And all of this is definitely influenced by the wishes of, you know, of papers and of data come from the Western world, the world that speaks English, because that's, you know, the most of the publications we have, and most of it comes from Christian settings. So it can't be really applicable everywhere. And so much so that if we have patients or families that slightly disagree with us, that want to come and die in ITU, that quality of life is not that important to them, then, you know, they want more, not less aggressive intervention. Then all of a sudden that becomes a problem. So for some reason, simply being or dying in ICU has become undesirable. And maybe that's okay for some cultures, but definitely not for the rest of the world. But somehow we've managed to normalize that belief that appropriate care comes because something will be undignified or because the patient will not survive. But that, I urge you to reconsider, is not really true, because we don't really know. In the majority of cases, we are uncertain. And what really changes what we think is patient and family-centered care is our cultural beliefs, and unfortunately they are really skewed by our Western ideas. I'm going to finish with this, because again, this is a very big push, right? We had a session about opening my ICU, getting the families in, and the families have been together. The patient was with the family the whole time, and why they're not together when they're in ICU. And of course, that is very important. We saw that during COVID. But again, let me give you a different kind of spin. This is a scoping review on the patient presence during ward rounds. And that's only an aspect of patient presence, of course, in ITU. But this is their presence during ward rounds. And I mean, this is quite complicated, but let me summarize it to you. We don't have much data out there. The majority of data shows that, you know, yes, it works. But look at where the data comes from. There are 16 studies. All of them, apart from one, are from US or Canada. And they compared completely different things, completely different styles, completely different outcomes. And this is what I'm trying to say, where the evidence is skewed by Anglophone literature. But let me show you something different. So this comes from the African setting, where healthcare providers were said, you know, what do you think about families being there when the patient deteriorated? And basically everybody, hated it. Because they thought they interrupted patient care or interfered with patient care because they were afraid of litigation, because they were, they increased their levels of anxiety, but also the family's levels of anxiety. It's a completely different picture from our African colleagues. And this comes from Greece, where I'm originally from. The same kind of picture is painted. So depends, of course, if you're experienced or not. But similarly, the signal is not so clear. And you have similar publications from Pakistan, from Iran, from Jordan, so definitely not from the Western Hemisphere, that definitely doesn't really look at this presence of families during ward rounds or 24/7 in ITU very favorably. I'm now going to conclude and say that patient and family-centered care, of course, is a concept that's very easy to endorse, and we all definitely mentally, conceptually endorse it. But I hope I've proven that at least some of it is very difficult to define and very difficult to actualize, to make into practice. The majority of the things we believe are Western-focused, Western-driven, then the focus is more to the West, and that's fine if we stay at the West, but our patients and their families sometimes are not from there. And I wonder whether we start moving from patient-centered care to the more humanizing kind of care, which for the patient and the family will be different, but for us might mean something different, something else. And for that, I thank you.
Thank you. Question from the audience? Any questions? Then may I ask you a question?
Please.
And in your ICU, do you allow family members to always in this ICU or just in some consultant time?
So yes, generally in the UK, we've got extended visiting hours, but not 24/7, 24/7 only around end of life. So we're thinking about flexible now, but we're not 24/7.
Okay, thank you. And for the time, we should switch, I think. Yeah. My turn, your turn. It's you.
So our final speaker in this session is Katarzyna Koftas, talking to us about listen to the patient and address their unrecognised needs.
Good morning to everyone. Thank you very much again for the invitation to participate in this brilliant event. I would like to say that I have no conflict of interest, and I would like to talk about what it means to understand the patient. In the ICU, we all, as patients and as human beings, have multiple needs. They are psychological, physical, and of social nature. And it is a systematic method of learning that we need to address whenever assessing those needs. To become critically ill is stressful, chaotic, and many describe their admission to the ICU post-admission as a horror. Many strategies have been used to reduce that stress and increase the well-being of patients in the ICU, but we are still very much behind. There's dependency issues and lack of control. There is lack of control of bodily functions. There is inability to make decisions. There is severe weakness and being restricted by all the elements that we put into the patient. And at the end of that, there's an inability to communicate. So these are all the needs our patients have, and we restrain them with so many interventions. We have written a short editorial a long time ago on the future of intensive care. It was focused on delirium, but one of the elements we underlined was that we should gain insight into the patient needs as part of the A to F, or we called it A to H, bundle. And when we focus on needs, we must understand, is it really something that we know how to do? And this listening matters. It's not just a soft skill, but a core clinical competency that we're not taught enough in medical school and postgraduate training. and it directly impacts the therapeutic relationship and the healing abilities that we have as physicians in the ICU. It is important because patients value us as those who take them seriously and those who understand. So it is an essential component of clinical care, not just all the interventions that we can do manually. Different conceptual frameworks were published to enhance effective learning, as you can see here. But the problem is that we're not listening enough. When you take the outpatient world and also the ICU, with those patients that we can communicate with, we interrupt them within the 11 seconds of initiating a conversation. We concentrate on our speaking and not on listening, and only 23% of the physician's time is dedicated to discussing quality of life, which for our patients might be the only issue. This is a study that I would like to draw your attention to, a qualitative study with a convenient sample of only 9 adults that have survived ICU and that were able to describe their experience in the unit they were in. And the analysis has identified 3 major themes that the patient's thoughts were revolving around, and it was acting as the captain, being a fellow passenger, and the patient experience of being on an isolated island. So acting as the captain, patients experience participation. They were responsible for setting their personal boundaries. And here I'd like to draw your attention to the fact that only those who are with minimal sedation or no sedation or adequate sedation will be able to participate in that cooperation and set those boundaries. So those patients who felt that where they were able to act as captain of their experience, they felt as equal to the surrounding world. And I would like to read a quote from one of those patients. When I felt that different activities were not synchronized and I did not have the strength to exercise, I said, no, you have to come back at another time. Try to put this in the perspective of an ICU workflow when there is no other time. It's either now that we do physical therapy, now we draw bloods, or it will be a little bit too late. And this is in opposition to what the patient need was. The patients acting as captains were most satisfied. They took initiative. They were able to initiate care actions, even if intubated, even if sedated. And their experience was positive as they felt they were listened to, taken seriously, and respected. I was in control by holding the endotracheal tube the whole time. I was a good patient because they, the healthcare professionals, were never worried that I would extubate myself. A very touching experience to me. The next theme was being a fellow passenger, when the patient felt invited to cooperate in their own care. So we were initiating interventions. We, as the ICU healthcare personnel, initiate a lot of different elements that revolve around the patient, and the patient needs to feel invited, being seen as a person with actual needs. That means patients expect to be informed in a respectful manner about everything that is about to happen. I was treated as an individual, and it was like I was part of the team. I trusted the healthcare professionals, and I accepted what was happening. This is a report of a patient who felt as a fellow passenger. Now, the worst experience was being on an isolated island when the patients were feeling they were not mentally included in the team, that the healthcare personnel regarded them as objects, as not part of the decision makers. They, and that was the most dramatic, were felt as ignored, with a feeling of not being respected as a human being. How deeply moving that thought that the patients carry on with them. This is part of the post-intensive care entity that we have. This is the baggage that they will be carrying with them through life. I did not experience it as questions. I experienced it more as statements like, now let's do this. Not is it okay if we? I had not said no anyway, but if I would have been, wouldn't it be nice with a question like, would you like to brush your teeth, instead of saying, we are going to do that. Now, this is a living experience of those patients that have survived the ICU, but what does it all sum up to? The inability to communicate triggers anxiety and discomfort. It causes feelings of insecurity, fear, and loneliness. And many studies have been shown that this is associated with pain, increased pain, more episodes of delirium, nightmares, memory gaps, higher burden of cognitive dysfunction, sleep deprivation after ICU, and delusional memories. And all of these memories are frightening, and many patients report ICU stay as horror, and we're not there to cause horror, we're there to heal. This is why it's so important that we change the attitude. And the intensive care unit journey, we have to be on that same pathway with the patient and understand that it is not the most important what matters with the patient, but what matters to the patient. This is the focus that we need to change in that intensive care unit journey. That has been my experience, that has been my iris, so to say, of my eye for the previous times. This is a graphic that we have prepared, but it was unpublished. It was rejected by one of the major journals. The paper was called "Do we do enough to address patient needs?" And we stratified it together. We wrote this with Wes Ely and Sheila Miatra. The first element was, do we gather enough information? So where to get the information from to address patients' needs? How do we know about patients' daily habits prior to ICU admission? Do we know their likes and dislikes? Do we have any information about the diet prior to admission, or sleeping habits, favorite music? Do we pay attention to any of that? And how to gather that information is another question. Not always the immediate family or the relatives will be good in answering these questions, but someone from the larger circle of friends might be more legitimate to answer those questions. Are we actually doing enough to orientate the patient? Are we doing enough to address pain and discomfort? And the third element is, what do we do with that information now that we have gathered it all? Do we eliminate obvious stressors immediately, or if the pain is reported, there is a lag of time before the pain medication is given? Is there enough time to provide psychological support? Is there enough time for cognitive exercises? And this all means changing the ICU working habits, and many will say this will impose additional burden on the ICU teams. And all of this are subjective assessments, meaning that the symptoms the patients feel will have to be reported by them, so we only have surrogates to identify distress or fear or anxiety. There are studies assessing nociception, but pain awareness is something that is fully subjective, so we cannot substitute fully one by another because we need patient subjective experience. And we, of course, have done, we as a community, healthcare community and different personnel providers, we have done a lot to try to understand what are the sources of discomfort and what are the sources of anxiety and how are the patients coping with the ICU horror, but it is always there. Do we do enough in management of nausea? We can quantify vomiting, but nausea is a very subjective feeling. And a subject that not many people touch upon and that is not really reported as post-intensive care syndrome range is sexual dysfunction. It is one of the most basic patient's needs, and this is not the subject that we touch upon. And there are very, very few studies that actually address that, that issue post-ICU. And the beautiful paper published in New England Journal of Medicine, when the summary of outcomes after critical illness is published, none of those elements mention sexual dysfunction. And when we see patients in post-intensive care clinics, or even in any other, if you would ask our colleagues, non-critical care colleagues who see patients in their clinics, how many, this is a domain of neurologists, they always ask about sexual dysfunction, so they see something that we don't even include in the core outcome set. And again, this is from the unpublished paper by Professor Miatra and Wesley and myself. This is the summary of the 10 steps that we think we could do to meet the patient needs. So first of all, we have to be vigilant in identifying potential human needs during routine patient assessment. Routine meaning every day, multiple times a day. We have to be proactive, because passive observation of the patient will not give us answers. The obvious stresses must be eliminated, so those that we associate with being bedbound, with having multiple lines inserted. We have to encourage the patients to self-assess, and in order to that, they, as I said, must be adequately sedated or live with no sedation. Those patients that are unable to self-evaluate should be assessed with a checklist of possible or likely needs that, as ICU community, we should identify. Now, as we gather the information from the family, we should create a checklist, and that checklist could be addressed every time we encounter the patient visit. Also, with the family, we should solicit feedback to show that the wishes and the feelings of the patient are taken seriously. And it has to be communicated to the patient and to the family, because sometimes the family giving additional feedback to the patient might be more productive or might be more experienced in doing that, having lived with the patient for the previous life. And again, we need to reassess regularly to identify new elements, and this also means, as the journey in the ICU progresses, how the personal preference change and what life goals are different after that difficult ICU encountered. So it all is about trust, about respect, dignity, that has been talked about so much during this session, to address patients' spiritual, physical, and psychological needs in the background of the culture they're coming from. And with that, I thank you very much.
Are there any questions in the audience? While people are thinking, I might just start with a question. Obviously, you spoke about needing a change in attitude, and how do you think, as a profession, we go about that?
It very much depends on the setting we're in, and it very much depends on the type of ICU that we practice. And that's a workforce or healthcare setting approach, but it has been said that what would be good for an ICU in the Western Hemisphere or in the, let's say, United States might not be entirely appropriate in other settings. So I think we're good at addressing and posing questions about the patient as a person, but I don't think we gather enough information from different cultural settings. And to me, that has been obviously the dominance of English-speaking encounters and the dominance of English papers, so to say, overflows the tracts in other cultures, in other places, in other geographical designs. And it's interesting for me because I have worked for the past 20 years in Poland, where the ICUs are closed and the families not really allowed at the bedside, although I've dedicated myself to opening ICUs in Poland. And I currently work in the United States when there's a different approach to ICU, where it's open and the families are allowed at the bedside. And I was convinced throughout my whole life that this is the game changer, and it truly is. So if we as professionals are to address patient needs, we need to involve the family into it, and we need to treat patient as a whole, patient, family, friends, loved ones, group, because we are not only taking care of the patient, but all of them in the same time.
Absolutely. Thank you so much. Well, that brings us to the end of a fantastic
Thank
session.
you very much.
And we will hand over to the moderators for the next session on the immunocompromised patient. Thanks all.